logging in already. So my name is Alex Ball. I'm Director of Communications and Engagement for the Clinical Commissioning Group here in Nottingham and Nottinghamshire. We'll just wait a minute or two for people to be able to log in and make sure they're connected to hear everything that's going on, and then we will make a start. So just bear with us 60 seconds or so, and then we will kick off. Thank you. Okay, so I make it just coming up to a couple of minutes past 6, so we will make a start. Thank you again, folks, for joining us. My name's Alex Ball. I'm Director of Communications and Engagement for Nottingham and Nottinghamshire Clinical Commissioning Group. Thank you for joining us here at this session tonight. This is our second round of public involvement and engagement for the Reshaping Health Services in Nottinghamshire and tomorrow's NUH programme. We last spoke to members of the public in November and December 2020, and that feels like quite a long time ago in sort of every sense of the word. A lot has happened in the world, I think, since then, hasn't it? But certainly a lot of work has gone into refining, updating, developing in more detail our proposals for the tomorrow's NUH programme. And that's why we're here today, to update you on that and start to hear from you, your thoughts and your feedback on that. We're taking our time to get this right, and listening to our local communities is a critical part of this progress. So we're here again to ask for your time, your thoughts, your input into this process to really test the latest part of our thinking. So I'll just do a quick bit of housekeeping, if we could just go on to the next slide. You'll hear from a number of speakers throughout this evening. We're probably going to talk for about 25 minutes or so, and then we're going to have a good chunk of time, around half an hour, to go through questions that people might have. So please use the Q&A functionality that you should be able to see at the bottom of your screen. Click into that and type your questions into there, please. We'll then take, as I say, a good amount of time at the end of our session to go through those and answer all of them if we can. But if there are ones that we need to take away and think about a bit more, then we will do that as well. Please type in those questions as we go along, either comments or questions or things you need clarification on. We really want to hear from you. So there's definitely sort of no stupid questions or nothing that's kind of off limits. And I will just say at this point, we are recording this meeting. We need to do that obviously to capture absolutely everything that we hear about for our analysis subsequently. So there will be a sort of a record kept of these discussions. So in a second, I'm going to ask our panel to introduce themselves, and then we will go through the sort of context and situation with tomorrow's NUH proposals, and then get into a bit more detail. But again, please use this as an opportunity for you to ask your questions. So I'll just quickly ask our panel to introduce themselves. Amanda, if you could say hello, please.
Hi, I'm Amanda Sullivan. I'm the Accountable Officer for the Clinical Commissioning Group. Thanks.
Thanks, Amanda. And Stephen, if you could say hello, please.
Hello, I'm Stephen Short. I'm a local GP in Eastleigh. Hi.
And Keith, can you say hello, please?
Good evening. I'm Keith Girling. I'm the Medical Director at Nottingham University Hospitals.
Thank you. We've got a number of other experts with us today from both the CCG and Nottingham University Hospitals Trust, and we may call on them and we'll introduce people as and when they might speak. But this is our main panel now. So that's quite enough of introductory bits from me. I'm going to hand over now to you, Amanda, to kick us off. Thank you.
Thank you. I'm going to start off with just a bit of introduction and a bit of background, really, about why we think this is a really potential brilliant opportunity for Nottingham and Nottinghamshire, and why really we do need to think about changing and adapting services across the NHS in line with our population changes. So we do know that people in Nottingham are living longer and therefore have more health needs. And there are many new treatments now that you can get locally and nationally that really would have been, you know, pretty much unheard of 5 or 10 years ago. And we do need to keep being able to adapt to new treatments. And, you know, really good news that people are living longer. And so we're looking all the time at ways that we can do that. For NUH, Nottingham University Hospitals, we do know that some of our services are not in the best place, and they may not be in the best location. They might be split across sites, and that means people who are needing the services and staff may need to sort of spend quite a bit of time travelling between sites, and it can be quite confusing for people as well. And also it does impact on the quality of care to some extent as well, if the workforce and the really skilled workforce is having to spend their time travelling across sites. So we do know that there are some, if you like, for historical reasons and how services have been working in the past, some opportunities there to think differently about which sites things are delivered on, and whether they are split across sites or more concentrated with other services in a particular area. And that can have an impact on how efficient our services are as well. So tomorrow's NUH, the opportunity to attract capital into the area, some more, you know, funding into the area to get better facilities, is not just about the buildings. It will also help to organise how the hospitals work differently and more in line with modern healthcare needs, but also help us with local jobs, local social and economic regeneration as well. So, and helping us with research as well, and really attracting the best people into the area. So it's got a lot of opportunities, and we're thinking about it, about the whole of that, not just exactly the buildings. Next slide, please. So how does all this fit together? So we have got the government new hospital programme, and we're thinking how that works alongside other services. Hospitals are a really important part of our NHS and our health system, but they're not the entirety of it, and we need to make sure that all the bits work together properly, and we've got really good local community services as well as excellent hospital services as well. And so we know that we have got challenges across both our health and care system, which means working with our councils of how the health and social services join together. And we have a programme of work called Reshaping Health Services in Nottinghamshire that brings together these different projects and plans. We have a programme that aims to sort of bring all this together and think about things like how mental health services work, how maternity and neonatal services work, how services work across from GPs, community services, referrals into hospital where that's required, and then caring for people at home as well. So we are confident that our proposals and the developing ideas that we're asking for your thoughts about are really aligned to our whole system, not just about the hospitals. So next slide, please. So what will this mean? Well, we're aiming, as I say, to give care in the right place at the right time. And that does mean looking at some of our, if you like, historical estates issues in the hospitals in particular, using the latest technology as well, and having really good fit for purpose hospital buildings, as well as attracting the right investment to get the best practice. It would mean if not having to work between two sites as much, can help with travel arrangements as well, and as I say, social and economic regeneration. Over the last 2 years, we've really innovated a huge amount to deal with the pandemic, and it's made us increasingly aware that we need our estates to be able to work flexibly as healthcare needs change over time, and we have used our hospitals really flexibly to deal with the pandemic and continue to do so. And as well as this unique opportunity as well, we are also looking at other areas of healthcare as well. This is not only going to be around the hospitals. We do know that if we move services, that will have an impact on travel times. And at this stage of the development of our proposals, we know that we've got further work to do on that. So next slide, please. Just as an overview of the proposals, you can see here that in very broad terms, and we'll come on with our clinical experts as to what this might look like. What we're proposing is that more, if you like, things that can be planned ahead, like operations, hip replacements, for example, cataracts, would be delivered at the City Hospital, with some emergency services going to the Queen's Medical Centre, so that they're closer to some of the other services that they work very closely with. And cancer services continuing across both sites. And then also, we are thinking that we would like a new women and children's hospital at the Queen's Medical Centre, which would mean bringing together the vast majority of maternity care to be delivered at one site. So I'll hand over back to the panel. Thank you, Alex.
Thanks, Amanda. And straight over to you then, please, Stephen, to get into some of the detail.
Thanks, Alex. And I'm going to talk through some of the proposals, the outline proposals in 3 service areas. But before I do so, I just wanted to make something very clear. We have 3 things which we're trying to achieve, and those 3 things are the best outcomes for patients, a really great experience for patients, and efficient use of our resources, our precious resources, whether that be people, beds, space, money, or indeed equipment. So those are the 3 priorities that we've brought to bear in thinking around these care areas. And the first care area is family care, by which I mean maternity, neonatal care, and gynecology, which it is envisaged would be moved from the City Hospital to the Queen's Medical Centre. Antenatal and postnatal care would be retained at both hospitals, but a midwife or consultant-led birth would take place if in hospital at the Queen's Medical Centre. There'd be no option to give birth at the City Hospital. Is the outcome of that discussion. Fertility services for men and women would be located within the proposed Women and Children's Hospital, as Amanda mentioned, which is to be envisaged to be located at the Queen's Medical Centre. So those are the proposals around family care, and we have the opportunity in a moment to talk about some of those if you wish. So if you just move on to the next care area, please. The next care area is adult elective care. Now, elective care is a kind of a term which we use to describe care that is planned or is anticipated, as opposed to care which is unplanned, unexpected, or an emergency. And what we propose here is to separate out planned care from emergency care in surgery, and make the City Hospital a real national and international exemplar of highest quality elective surgical care, to eliminate the disruption that often occurs when the emergency demands encroach on the bed space, so the beds available to patients who are coming in for elective care, who are unable to get into those beds, and sometimes have the deeply frustrating experience for everybody of having their procedure cancelled sometimes at the last minute. So we hope very much to be able to prevent that in the future by separating out elective care, planned care at the City Hospital, and emergency care primarily at the Queen's Medical Centre. Some operations though would continue at the QEMC. You'll be aware of our eyes and ears facility at QMC, and we envisage that will continue. And we also want to offer more elective care where it's possible in community settings. And we do this already in a number of areas like gynae, musculoskeletal medicine, podiatry. And increasingly, we'll see the opportunity to move tests out from the hospital into the community, sigmoidoscopies, cystoscopies, hysteroscopies, things like that, which will increasingly take place in the community and for the convenience of patients and where they're safe and effective options to do so. My final area that I wanted to outline is actually about outpatient care. Now, outpatient care clearly is the area which perhaps most of us are more familiar with. This is where GPs require support from specialists, and historically we've referred to the hospital for an outpatient appointment, which has taken place in the hospital, but at other areas around Nottingham as well, such as the treatment centre and Rope Walk House up near the Old General, and in some community settings. And our aim here is to try and continue to provide care that's designed with the patient's interests at heart. And increasingly, we'll see opportunities for patients to be encountered and looked after by different professional colleagues by different modalities. If I make an example, a personal example, I'm a patient of Nottingham University Hospital. I see my consultant annually, face-to-face. At 6-month intervals, we have a video consultation. I have a telephone call with my specialist nurse, and I have a telephone call also with my physiotherapist. It's very helpful to have care in that way. It's massively less disruptive than it otherwise would be. I don't have to have difficulty in parking or the expense of parking. The care is personal. It's every bit as good in my estimation, and for many other people who are enjoying care in the same way, it's an ideal opportunity to experience care in a much more convenient and accessible way. It's not the case for everybody. There are some conditions which just don't lend themselves to this type of care, and some patients who would prefer not to have this type of care. That's absolutely fine. There's no expectation that we'll be demanding or mandating a type of care on an individual, but actually we're providing greater opportunities to receive care in different ways, using the new technologies of telephone, video, which we've used very much in general practice during the COVID pandemic. But clearly, I do want to make it very clear that if people are able to do so, that's great, and if they're prepared to do so, that's fine. And also, if it's clinically safe to do so, that will become an option. So, and also increasingly, we want to avoid the frustrating experience of coming up multiple times to the clinic, to have a series of investigations, and we want to move to as far as possible to a one-stop shop type approach, so that everything that's needed to help the consultant or specialist nurse or therapist support the GP in delivering your care is available at that first opportunity to be seen, and it's hopefully much more efficient in that way. So those are 3 care areas which I've outlined, and hopefully we'll get some opportunities to have a chat about them after we've passed over to Keith, my colleague from NUH.
Thanks, Stephen. And I want to just pick up emergency care in the first instance. And of course, this is an extremely important aspect of care for our population. And it's absolutely our ambition within emergency services that we ensure people are seen by the right staff at the right time, first time. We've learned an awful lot about emergency care over the last couple of years. Services like NHS 111 have become more popular and responsive during the pandemic, and some of our learning has changed some of our thinking from the last time that we talked to the public about our proposals. We absolutely want to reduce emergency transfers between our hospital sites, but as you've heard already, we also are very committed to relieving the winter pressures at the city hospital so that we can maintain a planned care programme throughout the year. However, some of the specialties at City are delivered from purpose-built facilities or are linked to each other clinically, and it doesn't make complete sense for us to move those to the Queen's Medical Centre at this stage. So we would absolutely maintain Queen's as the main admitting site for A&E and the major trauma centre. some of the urgent and emergency care that's currently provided, particularly within oncology and haematology services at the City campus, would move across to Queen's. But some of the other urgent and emergency specialties, as they're listed here, would remain at the City. And so it'd be interesting to hear your thoughts on that in a few minutes. And then moving on, the other area that we want to just talk to you about is, again, hugely important for our population in terms of cancer care. And we know that the numbers of people that are diagnosed and living with cancer continue to grow year on year. And we also know that the treatments that we're seeing for cancer are changing all the time. And whilst we're looking at tomorrow's NUH and a future delivery, what we can't be confident of is what those treatments will all look like in 10, 20 or 30 years' time. So what we can do is try and make sure our facilities are fit for purpose, no matter what happens in terms of that cancer care. So the objective within cancer care is to maintain diagnostic, surgical and outpatient treatments on the City Hospital site, including chemotherapy and radiotherapy facilities. And this is for people that are undergoing initial diagnosis or ongoing treatment for their cancer. That also means that they continue to benefit from services at the City site, such as the Maggie Centre and the palliative care work that is undertaken there. But for patients requiring inpatient care and emergency care around their cancer, those inpatient beds will move to the Queen's Medical Centre. And there will be availability for some radiotherapy and some chemotherapy services at the Queen's as well as at the City. And of course, the cancer care services work really hand in glove with our primary care colleagues in the GP surgeries and the community services in order to allow us to deliver a care across the whole pathway. And finally, the move of oncology and haematology cancer services to Queen's Medical Centre will allow us to co-locate that with our research and innovation teams. And we know that research is extremely important for the delivery of cancer care. And so the links with the university and with the research and innovation teams really give us the best opportunity to deliver the very cutting edge treatments to our patients in this really important area. So we'd love to hear your thoughts on that in a bit too. And I'll hand back to Alex.
Thank you, Keith, and thanks to Amanda and Stephen as well. Hopefully that's been helpful for people to have that sort of overview. Excuse me. So excuse me. So whilst we're just sort of wrapping that up, and I'll encourage you again to click into the Q&A section and type in any thoughts or feedback or questions that you've got. We'll come on to those in just a moment. I thought I'd just quickly outline the sort of what happens after this stage. So we are currently in what's called in NHS land a pre-consultation engagement period. So this is, as we said, we're at quite a developmental stage where we've got some proposals that we put in front of you, but this is definitely still at the stage of wanting a lot of detailed input, still lots of thinking for us to do. So that's where we are currently. As we gather the feedback from that over the next sort of the remaining 10 days or so of this period, we're then planning, we hope, for a more formal public consultation later on this year around the autumn time. And that would then give us hopefully a kind of final set of inputs and comments and feedback from public and other stakeholders to enable us in about a year's time to make a decision on the way forward, which would then potentially start us off on the kind of delivery of what is a very long-term programme. Probably takes us to around the end of the decade in terms of final completion. So a number of steps still to go, but as we've been sort of saying, I think quite consistently, a really key moment for people to be able to put their thoughts on the table and let us know what they think about what we're proposing. So again, I'll just remind people, this is the Q&A button that you should be able to see at the bottom of your screen. Please do tap your questions into there, and we will start to go through them in just a minute. If we could take the slides down, actually, so that people could see the panelists. Thank you. Thank you, Chrissy, for kicking us off. Really great question here. So in my experience, clinical care is excellent. However, administrative support has not been so great. Would these proposals be able to address quality of supporting services? So I wonder, Keith, if you want to talk a bit about this, because, you know, the way that the services are all joined up is a key part of our proposals, isn't it?
So thanks, Alex. And yes, thanks for that question. It is absolutely fundamental that we get the administrative support right for the clinical services. And by streamlining the services and the approach to those services, we'd absolutely hope to do that. So I think that's a key part of what we will look to do through this. So thanks, Alex.
And Amanda, as we've sort of said along, it's not just about the big improvements potentially within the hospitals, but into the other aspects of the health and care system. So I wonder if you want to add a few words about how we might think about that.
Yes, thank you. So I think there's two sort of key areas and they're very linked. So one is, I did refer at the beginning to the use of technology, and increasingly we will want to make sure that our care records are joined up across GPs, community health services, the hospitals, councils where that's important and helpful if people are receiving support at home as well. So that technology and the way we work to join up that record, you know, with people's consent and things as well, is going to be a part and parcel of that. Partly because people say they have to keep repeating themselves and things like that, but also more so that you can control your own appointments online, look at your own records, look at test results and things like that, and have that much more joined up. So that will be definitely part of the work that we do in the coming months and years as well. And then the other element is how all the clinical teams work together. And we've got Stephen and Keith here today, who are sort of from, if you like, general practice and then the hospital services as well. And what we're doing as part of our work going forward is bringing GPs, hospital doctors, other professionals to work much closer together and work out where in your journeys, as you know, you might need a referral, you might go to your GP with some troubling symptoms, you might need a referral, some expertise. How can we do that best and work out between the whole of the NHS how your services will run best? And that will include, obviously, I think we need to include the administrative side of it, because that is really critical for the smooth running, as I think is at the back of this question. But the technology, the relationships, as well as the administrative processes, all will make a big difference to how people experience care. Thanks, Alex.
Thanks, Amanda. We've had a number of further really helpful questions in as well. There's one that's quite detailed. I'm just going to take a moment to digest, but there's a couple of slightly shorter ones that are probably mainly for you, Amanda, but I'll bring Stephen and Keith in as well. So a question around social care. So how is social care integrated or on board with the plan? So Amanda, I wonder if you might want to pick that up, but then perhaps Stephen as well. I know you do a lot in your practice around working with wider parts of the social care setup as well. So Amanda.
Yes, thank you. So it's linked in a couple of ways, actually. One is at quite, if you like, front line. And what we're doing is developing how closely we work as the front line between council and the NHS. Some of that happens in our communities, and we've got different what we call places or localities. We've got different areas within our overall patch where those teams are working more and more closely together and more influencing the plans, and we're looking at, you know, more and more sort of joint budgets between the NHS and councils as well, in order to be able to do that. So that's happening very much at the front line, and the people working in those areas doing joint planning for how people, you know, how people's care is delivered, and more day-to-day liaison. And then what we're also doing as part of, if you like, the developments of the NHS as a whole, is developing something called an integrated care system, and that in it will have a joint, it will be a, you know, in law, or, you know, as we anticipate anyway, things go according to plan, that councils and the NHS will jointly plan to meet the needs of the health needs of the local population. So we'll have like a formal role in joining those things up and thinking about how we allocate resources. And then there will be the frontline work, and what we'll do is work so that you get a kind of frontline informing that overall sort of priorities, and then you've got the councils and the NHS working at more of that strategic level to join it up. So it'll happen, you know, in practical terms and in terms of how resources get allocated as well. Thank you.
Thanks, Amanda. Stephen, I wonder if you could just give us a little bit, because I know you do an awful lot of work in your what's known as a primary care network, working with wider social care.
Indeed, thanks, Alex. And as Amanda says, we are in the start of a new policy called integrated care, and integration means, of course, bringing more and more things together to make things better. And where this is happening at different levels throughout Nottingham and Nottinghamshire and Nottingham City, but at a very local level now. GP practices in neighbourhoods and localities are coming together to work together explicitly on behalf of the population of that locality, and with other services such as community services, that's the district nurses, for example, and community matrons, and the third sector organisations, voluntary sector organisations, and social care, to understand how we can better meet the patient's needs, because it's not always necessary to respond in health to a health need. Actually, sometimes the health need is actually better resolved through some social care intervention or social care support. And we're designing those new types of offers for patients now within these organisations called primary care networks, 20 of which exist now across Nottingham City and Nottinghamshire County, and which will be increasingly influential in the way health and care is experienced at a very local level. So it's a new policy. It's only just started. We've only at the foothills of it. We're making rapid progress, but certainly it does feel as though genuinely we are bringing things together to make things better.
Thanks, Stephen. So I'll move on to a really helpful question. I'll bring you in, Keith. So it's particularly around the current cancer sort of service. So some quite powerful feedback, really. The citizen here talks about patients having to wait for hours in crowded places at the city, for consultants running late, you know, having to undress in public areas, waiting, things not being joined up. So the question, which is really good, what's being done to treat patients now with care and respect, rather than sort of necessarily waiting for what could be a bit of a longer term programme? So Keith.
Thanks, Alex, and a really important question. And the Tomorrow's NUH programme has allowed us to see the direction of travel that we are suggesting that we'll take, but that's many years away, as you're indicating. Even if the proposals all go through and are all delivered on time, then it will be a number of years before we see that delivered. And so we're absolutely turning our attention to what do we do over the years in between now and the Tomorrow's NUH coming in order to improve care for our patients. And we recognise that a number of parts of our estate at the city are very poor and not really fit for the modern practice. Some of them have been in place for many years, and we have a developmental plan that enables us now to progress that estate in a stepwise fashion over the years in between now to tomorrow's NUH, depending on the outcome of the consultation and the final model of what tomorrow's NUH will be. So that's very much in our minds, and we're already doing work on refurbishing some of our ward areas and making that better for patients. So we're absolutely not waiting till 2025 or 2030 or whenever tomorrow's NUH comes in to improve dignity for patients. And I'm really sorry that that's been the experience of somebody on the call today, but we absolutely need to and are committed to improving things in the meantime.
Thanks, Keith. That's really helpful. And I'm sure if there are specific concerns from this individual around the care that's been delivered, the relevant teams would be happy to pick those up. So we can certainly look into that if that would be helpful. One for you probably, Amanda. So a bit of a technical one, but a really important one. So if the proposals mean changes in locations, will you be completing robust quality impact assessments to ensure patients are not disadvantaged? And then will provisions such as Medilink or good transport links be in place for the public? I'll bring other colleagues in as well on that second half. But Amanda, to you first.
Yes, thank you. So yes, we will be looking at impact assessments, equality impact assessments, looking at travel times, all of those things. And when we do our, as Alex described, we will be doing a formal consultation later on in the year. We will, if you like, put all that information to you so that you can actually see. So we are going to do further work to understand that. We have already looked at that, and we will be continuing to look at that in a lot of depth as we develop the detail around these proposals. So yes. In terms of the sort of travel times and other things and the impacts, what we would do is make sure that we'd work with councils and we can describe travel times in terms of, public transport access and things like that. So we would consider that also as part of our, if you like, next stage in the development of the proposals, and make sure that people can see what the impacts would be. Thank you.
Thanks, Amanda. Probably one, I'll move on, probably one again for you, Keith, but Stephen, you might want to come perhaps as well. So I would like assurance that these changes will address waiting times for cancer treatments and elective care. So Keith.
So we're absolutely committed to dealing with the backlogs that have occurred over the COVID period. Again, we're not going to wait till tomorrow's NUH build to get on top of the waiting times that we're currently seeing. The teams are working really actively at the moment to manage those. Going forward, within the tomorrow's NUH proposals that we've got on the table, it's really to try and make sure that we can maintain planned care work throughout the year that doesn't get disturbed by emergency care work. And there's a lot of cancer work that's actually planned care work that we plan ahead of time that has been impacted through COVID, but also is impacted if we get a very severe winter with a severe flu bouts and such like at the moment. So by separating out the planned care work at the city from the emergency work at the Queen's, particularly in cancer areas, we'd absolutely look to enhance and maintain delivery of the cancer targets, because those are really key for us to know that we can deliver the best care for patients and the patients can get the best outcomes. So that's very much in the forefront of our mind as we've been looking at what the options might be for cancer care delivery going forward.
Thanks, Keith. And Stephen, I wonder if you might want to bring a bit of perspective on this, because you do this day in, day out, don't you? Sort of working with patients, with citizens, talking to them about their options for treatment. Sometimes it is an operation, but there might be other options as well that don't need them to go to a hospital that might work. So have you got any thoughts on
yes,
how
so if I may then, Alex, the next question is also about prevention and addressing health inequality, and it does touch on that as well. Currently, the system costs what it costs because of the way it's set up, and actually we know it's our colleagues in hospital, our heroic colleagues in hospital, have extraordinary service demands and burden, which actually means that sometimes care is delayed, it's sometimes duplicated, it's sometimes less efficient or less effective than it should be, and sometimes it takes longer and patients are away from homes for longer. That's no one's fault. It's just a question of it's sometimes just an observation made of a system under duress and a system in distress. Along with this investment and the opportunity to build these new facilities, there's an absolute guarantee that we look at the services at the same time, and we make sure that we develop new pathways of care which are safer, which are timely, which are effective, which are efficient, which are more equitable for patients, and which give them a really good experience. And the evidence around that is actually that such care is cheaper than the care that we currently offer at the present time. And yes, absolutely. If we are able to spend less supporting patients' needs in the hospital where it's appropriate to do so and where it's safe to do so, it does create the investment opportunity to invest in upstream interventions around well-being, lifestyle behaviours, prevention, early detection, prevention and mitigation of risk factors and prevention of long-term conditions deteriorating over time. So genuinely, there's a virtuous circle here, which actually it has proved elusive over years, and it's still ferociously hard to achieve, but that is our explicit intention and objective.
Thanks, Stephen. That's really helpful. And you've led us nicely into the next question, which talks particularly about prevention and addressing health inequalities. Amanda, I'll probably bring you in here because the question's around, is funding available to enable the upstream prevention agenda and reduce the strain on urgent care and hospitals? I wonder if you could talk a bit about that.
Yes, thank you. So there's a couple of really important things that we're doing around how funding is used and allocated. So one of the things is that we are doing more, as I mentioned earlier, more joint planning with our colleagues in local government, and that includes public health as well, and there are sort of experts in prevention who work in public health alongside, and what we're doing is bringing together public health experts along with doctors, nurses, therapists, social workers who work in all of those different areas to bring all that different expertise together to jointly plan. And what we'll be doing over time is to work through different, if you like, different areas of spending on healthcare and thinking, what could we do to maximise the benefit of that money on the overall health outcomes of those people? And what would be a more effective use of that money by intervening earlier to either prevent disease or prevent diseases getting worse? So, and we are increasingly getting the evidence and the data to be able to do that, but that won't happen overnight. That will be a period of time, because obviously what we can't do is destabilise existing services, but we will increasingly be planning for that. And the other thing that we'll be taking into account is what else alongside healthcare influences people's health. So that might be how you live, what sort of housing you're in. And that's why I think there's a lot of benefit in the NHS working really differently with other partners, local government, but other across the whole of the public sector as well to do that. And with the voluntary sector, because often the voluntary sector have got really good insights into things that are going to be helpful and are able to, you know, again, help people's health and give really, really brilliant services in local communities. So we'll be doing all of those things to sort of gradually move some of the dials, including experts from across the whole system to really, you know, jointly work through with our citizens how we could do that without destabilising. But that's going to be a big priority for us in the coming years. Thank you.
Keith, did you want to come in on that as well then, please?
Thanks, Alex. It's such an important question, and something that even in hospital we're very focused on, because we recognise that when people come to us for care, then there's an opportunity to give them advice on healthy living and on things that they can do to help themselves in the future. And we're embarking on, or we've already embarked on, a whole number of programs around working with colleagues from across the system on smoking cessation, on alcohol advice, and on exercise programs, and even for people planned to undertake cancer care. We're now not thinking of this as a waiting time, but as a preparation time before you have your surgery, so that we know that active exercise prior to surgery, however limited that can be, can make a really big difference to the outcome from that surgical intervention. So there's a whole number of programs that we're embarking on in that space at the moment, through the hospital as well as in the community.
Thank you, Keith. Really helpful extra detail. Another quite detailed but really important question here from John, who highlights the issue that we quite often read about in the press, don't we, of people who are ready to go home. They've had the treatment they needed in the hospital, but they can't go home, either because their home might not be quite ready for them, or they need to go to a different home, a care home or other residential facility. And John rightly highlights that kind of jams up the whole hospital, doesn't it? He's got a specific proposal around a sort of what he calls an intermediary facility away from the hospital to do that sort of short-term care, to maybe then free up other parts of the hospital. I wonder, Keith, that might have been something you considered, or if you have any reflections on that or other solutions to that problem.
Thanks, Alex. And I'm sure Stephen or Amanda might want to come in on this, because intermediate care is an absolutely important part of supporting patients as they're discharged from an acute care facility back into their home facility. And there's a lot of work going on across our system, our healthcare system at the moment, to bridge that gap. Amanda may be a better place to talk about some of those initiatives.
Yes, thank you. So yeah, this is very much top of our agenda, actually, and what we've done a lot of work in a number of areas. So I talked about how we're bringing teams to work together more around that sort of prevention side, but we are also doing that around discharge, and this is something that has really accelerated during COVID. And we've looked at how, you know, social workers, nurses, doctors work together, and that's helped us improve some of our processes and assessments and reduce delays in that way, which starts to help. And what we've also done is thought about how best to increase some of the intermediate care facilities, partly to be able to take more complex patients and therefore take them from hospital with some quite complex needs, but also just increasing the amount of, if you like, interim care home placements, which we have done a lot of over the winter to help us with the Omicron wave, as well as the sort of winter wave. And what we're doing now is working through, again, jointly NHS and councils, how much support people need at home, because that's one of our big blockages, is being able to get people at home with the relevant support. And we're just working the plans up currently now to increase that, and again, jointly with our council colleagues. So in a sense, in some areas, the hospitals run those intermediate facilities. Sometimes it's community services. In a way, it doesn't really matter who runs them, as long as they all work together and we've got the right sort of levels of capacity in the right place. And that's very much the work that we're doing currently. But there is a lot to be said for different partners working together to avoid delays in between the different stages, so that all of those things are part of what we're currently doing, and that's one of our big priorities. It has been over the winter and going into next year, that is as well.
Thanks, Amanda. That's really helpful, and lots more work will go on that. That's it's a big focus. Really helpful question here from Fiona. I think Keith and Amanda will both want to come in on this. So the plans sound to be well thought through. Will they require an increase in the healthcare workforce? And if so, how realistic will this be from a financial standpoint? So Keith, to you first, please.
Thanks, Alex. And yeah, great question. And obviously really important that we get the workforce piece right, to sit alongside the service change piece, to sit alongside the estates piece. And a complex jigsaw it is. And within the proposals as we've got them at the moment, there are really significant implications on workforce in different ways. So we presented a while ago that actually bringing together the maternity services so that there's a single maternity unit and a single neonatal unit, as opposed to having services on both Queen's and City, will actually make that a far more efficient service to run and require less staff than if we continue to expand both the Queen's and the City. So there's some efficiencies of staff working in that way. But when we come to planning to have a radiotherapy service on the Queen's site and a radiotherapy service on the City site, then whereas we've got 2 radiotherapy centres at the City at the moment, the planning can be done in one common area by one team. And so we would need to think about some additional staff in the radiotherapy service if we were to have a centre on both Queen's and a centre on City. And so really at a service by service level, we're having to go through and fully understand the overall implications for staffing for the proposals that are made. Our sense at the moment is that overall, the total number of staff may not change very much because of the winners and losers, if I can call it that. But actually the nature of some of those jobs will be different from what they would have been if we'd kept services separate or on different sites. But there's a lot of work for us to do to get that right. In terms of financial viability, the case is being constructed very carefully to look at not just the capital costs of the building, but also the running costs on a day-by-day basis, so that we can be assured that we will have an affordable plan at the end of all of this. So that's absolutely being taken into account as we go through.
Thanks, Keith. I wonder, Amanda, if you just wants to come in on that final bit, because I do think that's really important, that we can be sort of confirming to people that we've calculated the cost of this going forward, and we're sort of confident that this is a sensible plan, as it were.
Yes, indeed, and we do believe it's feasible and affordable. Yes, we do, and I think with the workforce, I think as Keith sort of alluded to, it's not necessarily about the money; it's about getting the people with the right skills, and so we do need to make the best possible use of people who are highly skilled, but also develop new skills. And from our local people as well, we want to develop our career opportunities for local people as well. So all of that is really important. Yeah.
Thanks, Amanda. We've just got about 5 minutes or so left. There's one more question that we'll come to in a second. But there was one question that was put in around mental health services. So there's been a written answer put in by Lucy Dadge, who's Chief Commissioning Officer for the CCG. But I thought it would be a useful one to highlight in case people hadn't quite seen this question, people on the call. So the question was, I have real concerns about the lack of specialist mental health intervention in urgent care. having used A&E several times this year, the waiting times in care is horrific. On top of this, lack of mental health expertise is so evident. Will this be addressed in the proposal? And Lucy's touched on some of the really important elements of the proposal around some of the way the buildings are proposed to be constructed to make sure there's really good quality fit for purpose facilities, particularly in the Women's and Children's Hospital, to make sure we've got the right setup there, and also mentions the liaison psychiatry service and how we're going to be really sort of boosting that up. But Keith, I know this is a really big focus for you and colleagues as well, so you probably want to talk to this too.
Yeah, thanks, Alex. And Lucy's answer is absolutely spot on. We're ever increasingly aware of the link between physical health and mental health, and the need to work really in tandem with mental health care providers as well as our teams looking at physical health. We absolutely recognise we haven't got that right all the time over the last years, and there's much closer working going on now between the healthcare trusts that deliver the mental health care provision for Nottinghamshire and ourselves, and we're having teams that are working much more in tandem together. And as Lucy has said, within the plans, we'll be looking to make sure we develop the right space and facilities so that the mental health needs of our population can be met at the same time as their physical health needs in the right and appropriate way. And that's not by any means suggesting that there's going to be that Queen's is going to turn into providing primarily mental health. That's in addition, and to support the physical health treatments that we will continue to provide. So through the emergency department, there's absolutely a need to expand that work, and through the Women's and Children's Hospital, as Lucy has said. So that interaction between us is strengthening all the time. And I think by the time we get to tomorrow's NUH, we'll be looking at that integrated working that Stephen and Amanda were talking about earlier, absolutely being much tighter between physical and mental health care provision.
Thank you, Keith. So a couple more questions. So Amanda, a question following up on the role of the voluntary and community sector. So is the intention to signpost appropriate funding sources and support the voluntary sector and be able to access funds that provide that essential activity? I think this was particularly linked to the discharge piece, but it's a wider question as well.
Yes, thank you. No, and I did mention it, and I think I mentioned it in relation to other services as well. But so yes, it is. We do see the voluntary sector as a really essential part, or and partner really with healthcare, and we're working more closely with the councils on this. And we're really fortunate also that we've which Alex is working on, is we have actually got some national additional funding to think about how we develop our relationships more closely with the voluntary sector, so they can sort of really influence how plans develop really on an ongoing basis, which is great and necessary. And what we're also doing is we're working, we call them place-based partnerships, but they're sort of local partnerships, and we're bringing the voluntary sector into those. So they cover areas like the city or South Nottinghamshire, for example, and they really are developing very strong working relationships in local communities with members of the voluntary sector. And what we're also doing is helping, if you like, helping health professionals to know to signpost. So we know that there's lots of voluntary groups that GPs may or may not know about, and so we're getting more sort of better ways of bringing that to the attention of our practices, so that they can signpost into all the into relevant charities as well. So we are looking at how we work with councils to make sure the funding gets there. We're looking at how we include the voluntary sector more to influence the plans, and we'll have a closer relationship, and also more in local communities and how we join them up with the NHS as well.
Thanks, Amanda. I'll probably make this one the last question, and I'll bring Keith, and then I'll come back to you, Amanda, actually. So there's almost 2-3 bits in this question. So what impact will this have all have on services from Sherwood Forest hospitals? May patients choose where they're treated, or will this be decided by clinical practice or geography? So Keith, you'll want to comment on that, but then Amanda, I'll come to you as well to talk about, who we want to participate in this engagement activity. So Keith, to you, please.
Yeah, thanks, Alex. And again, a really important question. And all the way through our thinking around tomorrow's NUH, we have been engaging with colleagues from Sherwood Forest, who we see as an absolute key partner in the delivery of acute services across the county. And so we would expect that there would be some impact from the proposals that we're putting on the table if they're followed through, and possibly one of the greatest areas would be in maternity services. If we have no birthing unit at the city, then we recognise that there'll be birthing units at Queen's and at Sherwood Forest, and the citizens and women that currently use the city from that catchment between City and Sherwood may choose to go to Sherwood rather than to come to the Queen's, for example. And so we've been working with our Sherwood colleagues to unpack what that impact might be, and to make sure that the Sherwood Forest hospitals would have capacity for the likely movement of women if that were to be the case. In the main, although we've described a number of moves, many of the services that are currently configured would maintain their current configuration, and there'd be no impact at all. And in some services, we would be hoping to offer greater choice. For example, the radiotherapy service that we currently don't provide at all at the Queen's would be able to be provided at Queen's and City, and so give people a greater choice of movement of treatment. And I think the point that's made about how would decisions be made, well, it will be a mixture of all of the things that are on that list, Alex. So in some cases there'd be a clinical need for patients to go to one of the 3 sites, if I can call Sherwood, Queen's and City 3 sites. In other cases, it would be a geographical arrangement because there would be equivalent services provided, and so on. So we would be looking at each of those going forward. But Sherwood have been fully engaged in the conversations, and we wouldn't be making any suggestions of moves or changes to our service provision within these proposals that couldn't be met by a combination of Sherwood and Nottingham working together.
Thanks, Keith. And then just a final bit, Amanda, sort of question around, who do we want to participate in this engagement exercise, and give us their thoughts, please.
Yeah, thank you. I suppose the short answer is everyone who's interested and willing and able. So I think we want anyone who lives in the area or who might need services in the area from NUH or other local services, anybody who is a carer, anyone who receives care in any of the, particularly if you're in some of the areas that we are particularly talking about, and you've got some insights into what it is, and we've had some very powerful feedback today about what it's like to receive care from those services, then and what you think might make it better in the future that we should build into how we design this. Definitely all ages, all areas, if anybody lives in any area, because we'd like to have a bit of a spread from across the whole area, just to get some different views. Whatever your background, we're really interested. We will be trying to make sure that we do make ourselves as available as possible to different groups, different interests, different communities, different faith communities, all who've got a slightly different perspective and thoughts that we need to consider. So we'll try and make this as accessible as possible for people, both at this point and, you know, when we come to sort of, if you like, more formally consulting on more developed proposals. But really anybody who's willing to give us a little bit of time and thinking, really. So thank you to everybody who's here today. We really appreciate it, and there's some absolutely great questions, and we really appreciate your time and you're sort of thinking about this with us, really. So thank you.
Thank you, Amanda. I think that pretty much wraps us up perfectly. And as if by magic, up on the screen has come the web address for our detailed survey. If people want to complete that, you can also access that by pointing your mobile phone with the camera on at that QR code that we've all become so familiar with over the last couple of years during the various pandemic measures. That will get you straight to that survey as well. So thank you again for everyone who's come. Thank you for your questions. Really very, very helpful. There are 2 more of these events. So this coming Saturday morning and next week on the first Friday. So further opportunities if there are people you know of that might want to come along to a session like this. But that brings us to an end for today. Thank you to the panel. Thank you to everyone for coming, and see you soon. Thank you.